Our next speaker is Ms. Kristen Ogden from Families for Intractable Pain Relief.
Good morning. My name is Kristen Ogden. I'm really pleased to be here and I appreciate the opportunity. I'm the co-founder of a very small advocacy group called Families for Intractable Pain Relief. I'll start off by saying right up front, I am not a medical professional or a scientist. I am, however, a family member of an individual who has suffered from pain throughout his entire life. We just celebrated our 45th wedding anniversary 10 days ago. I have assisted him and been his caregiver and advocate for over 20 years. And more recently, the last 5 years, I have been more involved in advocacy on a broader level. Our group is comprised entirely of intractable pain patients and their family members. Family members are fully engaged in the care and the issues that their patient family members are experiencing today, and I'm here to talk to you about some of those issues and to suggest ways that we might make life better for these people. Our goals are to raise awareness of intractable pain and the challenges faced by those who suffer from it, and to advocate for continued and better access to standard and non-standard pain therapies to treat intractable pain. Well, what is intractable pain? There are numerous definitions, I'm sure, but I want to make clear I do not in any way minimize the impact of pain experienced by any person. And our motto, our goal, one of our guiding principles, you might say, is at the bottom of every slide here, that freedom from pain to the extent achievable is the most fundamental of all human rights. However, intractable pain that I'm talking about is a level of pain that is very severe. It's constant. It's not curable by any known means. It causes adverse biologic effects on the body's various systems, leads to a bedbound or housebound state, and early death if not adequately treated. And I would agree with Ms. Proctor, people do die from undertreated pain. What are the characteristics of intractable pain? I'll just point out a couple that I think are very significant for you. That it is, in fact, constant, 24/7. I have had the opportunity to become acquainted with many intractable pain patients whose illness fits the definition I just read to you. Their pain is constant. It can be effectively helped. Oftentimes it requires high doses of opioids to do that, but it can be addressed, it can be managed to enable these individuals to have a better life. But without adequate treatment, it is constant, excruciating, 24/7 pain. So I would ask you when you have a moment to just stop and think, what's the worst pain you could imagine having, or have had perhaps in your life, and think about what your life would be like if it was like that all the time. Every minute of every day, every week, every month, for years or decades. This message has been lost somehow. Most people don't believe this is real, but I'm here to tell you it is real, and my husband is one of these people. Other important points. The pain is so bad that it causes physical and mental incapacitation because you can't do anything but think about how you're going to get through the next few minutes. The underlying cause, incurable, not removable. In order to treat intractable pain, clearly it's our belief that a person must have already tried all the available avenues of what you would call standard care. But what you find is that these particular patients are not helped by standard care. So extraordinary methods and means are required in order to give them a decent quality of life. And my message to you is that that can happen. It can be done. Generally, unique personalized medication regimens are going to be required, which may include, as a last resort, higher dose opioids and other non-standard medications or therapies. We never want to come across or be understood to suggest that opioids should ever be the first-line treatment for pain. We don't agree with that at all. But higher dose opioids are necessary as a last resort for many patients when all else has failed, and that's what we're talking about. If pain is not adequately treated, centralization results. We have found that the World Health Organization's three-step analgesic ladder provides a good model to describe how one might go through the process of standard care and ultimately go to non-standard care. Throughout the 80s, step 3, wherein if steps 1 and 2 have failed, you move on with basically the addition of a potent opioid. When the latter was first created, there was no upper end defined on the dose that could be given. I think in today's environment where we have the CDC guidelines with the 90 milligram threshold, we have other guidelines out there in the states and different, put out by different agencies. Perhaps the 90 milligrams should serve as our threshold above which we could say standard care has failed. Extraordinary care is now necessary. Profile of failed patients. One important point here that I haven't spoken to necessarily. Patients become non-functional, and family members will be at their appointments with them saying, my family member needs help. We have tried all these other things. Nothing is working. My family member needs help. The underlying cause of intractable pain, as I've described it, can be thought of as being twofold or two-pronged. The initial injury or disease must have been severe enough to cause activation of microglial cells in the spinal cord and or brain. This causes neuroinflammation of the central nervous system, the spinal cord, and the brain. And this is what generates the constancy of pain, the 24/7, it never stops. Only the most serious diseases or conditions are severe enough to cause it, and we've given some examples there. The great majority of people with pain at this level or magnitude suffer from one of these illnesses that I've shown. Why treat it? Because it's the right thing to do, and because with appropriate medical management, that is often with high-dose opioids, patients' quality of life can be improved, their blood pressure will fall, they will be able to get up and be more active, and as they're going about a somewhat improved life, they are stabilized to the extent that physicians who know what they're doing and know how to treat these people can search for the true causes and try different treatments to try to bring down that pain and ultimately perhaps reduce the need for the opioid. I'm going to thumb through our 8 slides here that address the specifics very quickly, and I would ask you to come back and take a serious look at them. I started with my introductory slides to give you a context in terms of where we're coming from. We agree with many of Mr. Lawhorn's points. We feel that we're after the wrong target here. Very rarely do new abusers or addicts come out of the population of people that I'm talking about, but they are being harmed. They are being harmed. They are losing access to the only medication that gives them any quality of life and enables them to be productively treated for their underlying illness. We have a few myths and misconceptions, and I'm going to say them real fast here. Intractable pain patients like my husband, who does take a very high dose of opioids, are not addicts. They do not fit the definition of substance use disorder in any way. They demonstrate none of those behaviors. They are not likely to overdose or die. They do not get high. More myths, I invite you to take a look at these. Absolutely, they are not drug diverters or drug traffickers. What can the FDA do? And yes, ma'am, I am wrapping up here. We do think there are specific steps that someone should consider taking. Hold focus groups around the country and invite intractable pain patients at this level. I know you talk to a lot of chronic pain patients, but I'm not sure you've heard from very many intractable pain patients. Yes, it's difficult for them to travel in many cases, but their family members will be right there with them and will help them get to a meeting. If you'll announce one, I can guarantee that. They all are very frustrated because they do not feel they're being heard. Help us change the public narrative by acknowledging that people like my husband exist. He takes a very, very high dose, but he has been on the same stable dose for 7 years. It is not true that doses escalate. Establish through regulation a means to protect these patients, identify them somehow, and please look into establishing a training and licensing program to enable community-based doctors to treat these patients. As we baby boomers get older, there's probably going to be more of them, perhaps, not necessarily fewer. We hope the science advances to where the causes of this kind of pain can be more readily treated. Please take time to listen. Stop causing harm through inaction or lack of knowledge and denial of care. Thank you. Sorry I went over. Are there any questions?
Any questions from the panel? Thank you, Ms. Ogden, and congratulations on your 40th wedding anniversary.
Thank you.